Afternoon, everyone. Welcome to our board meeting. We're just waiting for a couple more board members, and we'll get started. Thank you. So, Christine, I see Barry's on and Stephen's on. Anything from Jerry?
I do not see Dr. Anderson yet.
Okay. We'll give him 30 seconds, but since we have a quorum, we'll get started very shortly. I'm sure he'll be along. Okay, well, I have 2:01. Quorum is established. Welcome to this afternoon's Maryland Prescription Drug Affordability Board meeting of March 24th. Call the meeting to order. And first item of business is the approval of the minutes, February 26th and January 27, which is a closed session. They were submitted to the board members ahead of schedule. Do I have a motion?
So moved.
Moved by Joe, second.
Second by Joe. It was moved by Stephen.
Moved by me.
Sorry. My bad.
No
Okay, we have a
problem.
motion and a second. All those in favor as submitted, aye.
Aye.
Opposed? Thank you very much. Our first, let me go to item 3. Christina or Andrew, any public comment requests?
Yes, the board did receive 4 written comments, which were shared with the board and posted to the website. We have one person registered to provide oral public comment today. That person will have 1 minute and 30 seconds to speak. Once I call on you, please state your name, the organization, agency, employer, or other entity with what you are affiliated, if any, and whether you are a consumer. And then please let us know what agenda item you would like to address. Once I call on you and you give me that information, I will begin the timer. So I am looking for Dr. Alan Krita Olson. Dr. Olson, are you with us? Dr. Olson?
Christina,
Hello, yes.
She just.
Okay, great. Okay. Can you please state your name, your organization that you're with, and the agenda item you'll be speaking to, please?
He's muted.
Oh, yes, you're muted, Miss Dr. Olson.
Okay. Sorry, just trying to get oriented. Yes, my name is Ankita Olson, and I'm working with the Community to Protect Health, and I'm a preventive medicine physician practicing in Baltimore.
Okay, I'm going to get the clock started. Can you see it on your screen? I want to make sure it's showing. No, okay. Okay, it started. I'll work on sharing. Hold on.
No problem.
Okay, you can begin. You can begin, and then I'll let you know when the time is up.
Okay. Well, good afternoon. Thank you, members of the board and staff. My name is Dr. Olson, as I said. I'm a preventive medicine physician practicing in Baltimore. I've seen firsthand how the affordability of prescription drugs determines whether my patients can successfully manage their health or suffer serious preventable complications. I regularly prescribe drugs like Jardiance and Farxiga to help my patients with type 2 diabetes control the condition and avoid life-threatening consequences like kidney failure and heart disease. But far too often, I see patients unable to access these essential medications because of the cost. I have a patient whose insurance does not cover it, so he either can pay $730 monthly or go without. And instead, he chose to buy the medication abroad just to afford it, but there's no guarantee that he's getting the actual medication that I've recommended. And many of my patients purchase insurance plans through the marketplace, assuming their essential medications will be covered, only to find out at the pharmacy that they are not, or that the copay is too high, leaving them in an impossible situation of deciding whether their health and financial stability, deciding between their health and financial stability. So while I have patients in the private sector that are having issues, I know I've also worked with veterans that have had access to these same drugs at far more affordable prices because the VA is allowed to negotiate their costs. And as a state, we've already led the way in setting fair prices for medical services. So I think we should continue to be an example in lowering healthcare costs by setting an upper payment limit for Jardiance and Farxiga, and the board has an
Time.
opportunity to do so. Thank you so much.
Time. Thank you. Thank you. That concludes our oral public comment for today. Thank you very much.
Okay, thank you, Christina. Next would be item 4 on our agenda, the cost review study. Number A, staff presentation. Andy?
Thank you, Mr. Chair. Christina will pull up the presentation. So we wanted to use this meeting to start to work through the cost review study process. Christina goes to the next slide. So as the board will remember, we have a cost review study process, and ultimately, as part of this process, the board may determine, according to our statute, whether or not the use of the prescription drug product has led or will lead to affordability challenges to the state healthcare system or high out-of-pocket costs for drugs, or whether the use of that drug has led to affordability challenges or high out-of-pocket costs, and ensure that whether the use that has led to the affordability challenges or high out-of-pocket costs is consistent with the labeling approved by the FDA or standard medical practices. And then also, we must identify the circumstances which the prescription drug product has or will lead to an affordability challenge to the state healthcare system or high out-of-pocket costs to patients under this regulation. So that's the ultimate outcome of what this process will look like. And in previous presentations, we've kind of worked through the flow chart of exactly how this process works. So we have gotten to the point where we are going to actually start reviewing the dossier information. So the board has selected 6 drugs for the cost review study process. There was obviously the full process to select those drugs. We've completed the RFI request for information for 4 of the drugs, Jardiance, Farxiga, and then Ozempic and Trulicity. And now we're at the point where staff has completed the analysis of the different elements. And then now the next step is for the board to actually consider each of the different elements as part of this dossier, and ultimately make your preliminary determination of if the drug has led or will lead to an affordability challenge for the state healthcare system or high out-of-pocket costs for patients. So that's kind of just, again, a high-level overview of what we're working through here. Next slide. So the dossier is a document that we've referred to many times, and basically the regulations allow the board to consider a number of different factors in making their affordability determination. So those are all articulated in the regulations and through statute. The board has assembled what we're calling our dossier, which is basically a document that contains all of the information related to the various factors. And as we've been going through this process, we believe that it's important to make sure that and ensure that the board members consider each of the different elements that are available. So what this document is, as it's being published, is basically the comprehensive list of everything that is available to the board to consider when making your affordability determination. We have broken the dossier up into different sections. So it's a little bit of a mapping exercise when you map from certain regulatory elements to different, kind of grouping them together in a way that is intuitive and kind of makes sense. So we ultimately expect the dossier to be about 7 sections. Today, we're going to go through 3 of the first sections just to kind of show you what this process and what the documents can look like. So we're going to go over the first 3 sections, which are primarily background information, some of the clinical information, and then also the regulatory approval and market context. In a subsequent meeting, we'll go through the other different sections and that include the other factors that are available for the board to consider. So on our website is board materials. We've published, again, these first 3 sections to start to go through the process. And I think these are just for Farxiga, just to show what the process looks and the different data elements that will be available in the dossier. Ultimately, we plan to publish the full document, all 7 sections of the dossier on the cost review study website. And then in a subsequent meeting, again, we'll go through the remaining sections of Farxiga and then ultimately all the sections for Jardiance in an open meeting for the board to consider each of the elements. And then ultimately the board can make their preliminary determination in an upcoming meeting. So at a high level, we'll go to the next slide and just work through the background information. So again, this is primarily to walk through the dossier document itself, and then also to let the board ask any questions on these different data elements, and then also just generally show the process of how we're going to go through and look at each of these different elements. So the first section is going to be the background information. And again, this is at a high level. This is just the identifies the drugs under review. It gives the proprietary name and non-proprietary name, and then also the NDCs that are under review. It is worth noting that a number of the NDCs are no longer active. So it's actually a pretty substantial list of NDCs. When you actually look at the ones that are currently used, it's a much smaller list, but it is important for us to consider all NDCs related to the new drug application or the biologics application. So with that, Christina, are you available to switch over to the dossier and just go through the first few pages to show the background information, basically the cover page? Yep, this is it. So as you'll see, it includes the NDC codes under consideration, the proprietary name and the non-proprietary name. You can scroll down a little bit more. Yep, and that'll take us to our clinical information. So do you have any general questions on the first part? I think, again, the main takeaway from the first part is just noting that it's a comprehensive list of NDCs from a database called RxNorm. So it is over-inclusive of NDCs compared to where I would say most of the volume is going to be. And that'll come out in some of the data that we share later. Any questions on section 1? Hopefully this is one of the easier sections. All right. So then if you go back to the presentation, Christina, we'll go on to section 2. And thank you for navigating, Christina. Appreciate it. So in section 2, this is going to be our clinical information. And this section includes the clinical information regarding the diseases and conditions treated by the drug, product under review. And the 2 primary elements are C1G1, the clinical information, including FDA indications and doses and information concerning the standard medical practice. And then also C1G2, the disease burden of the condition that's being treated by the prescription drug. So this is the staff's best interpretation of these 2 data elements. Christina, if you switch back over to the dossier. So you can see that between pages 2 to probably through 5 is the indications themselves. So this is primarily pulled from the FDA indications, the actual FDA documentation. But then we also need to look at standard medical practice as per the regulations. And to do that, we've also summarized key takeaways from the clinical guidelines that are available for each of the different indications. So hopefully this is a kind of board-facing and also public-facing document that synthesizes this very technical clinical information into information that you can use for the purposes of this work. It also hopefully summarizes exactly how these different therapies fit into these different drugs fit into the different therapies, so you can understand why certain drugs would be selected over others. And again, tries to consolidate things for a general audience where folks can kind of understand the different clinical implications. Next slide. Oh, sorry. If you scroll down, Christina, sorry about that. If you scroll down on pages 6 through about 14, That summarizes the burden of the disease. So a lot of this is epidemiological information, just under kind of articulating the importance, the clinical importance in terms of epidemiology, and then also the severity of the disease for each of the different indications that are included for the medication. So we do go include all the indications and then kind of the key epidemiological factors, as well as kind of the severity of the different diseases that are meant to treat as well. All right, so that's the clinical information, and we are happy to take any questions from the board, or if you want to let us know if there's anything that would be particularly informational, helpful from this information. We're always welcome board comments on that as well. Okay.
Does anybody have-
Finally,
Oh, I'm
we will
sorry, go
switch
ahead.
over to the slides again, Christina.
I have a question, Andy.
Yeah, go ahead. Dr. Renfro.
So regarding the prevalence information, the epidemiology information presented, just wondering whether in the research the staff came across data from Maryland on co-occurrence of the 3 conditions or 2 of the 3 conditions in Maryland.
We can look into that. I will
Usually
take that
easy
back to the
find,
team.
but I wondered if you found that.
Yeah, we can take that back to the team. I don't think we have that in here because a lot of this work is kind of summarizing available literature. So we'll have to kind of see if that was done. It is something we can try to do based on the different information that's available. So I will take this back to the team and see if there's any way we can try to hone in on that. But I will note that as a piece of information that the board would be interested in.
Yeah, I definitely would be interested in comorbid just because of what we know clinically in terms of cardio-renal, diabetic conditions. And then in Maryland, just looking at these data and the prevalence being above average or above rates for the US in Maryland, just any information we have on comorbidity or co-occurrence would be very helpful.
Yes, and we can look into it. And to your point, there is extremely high kind of correlation between the different comorbidities. They're often, have the, one indication causes the other. So I think we can even take kind of national numbers and see if we can make even just inferences based on the Maryland population or something like that. So we can hone in on that and work through the comorbidity element for you. Thank you for flagging. So we'll go through each of the 2 elements here. So this section, the clinical information section, focuses on the indications of the use of the drug and the dosing used for the drug. To do this, staff reviewed the most recent FDA label, and then again, any published clinical guidelines. So that's again kind of getting at the standard medical practice as required by our statute. Next slide, Christina. And again, going to the disease burden of the condition. So again, the regulatory element is pretty broad. So the staff did a lot of work kind of building out exactly what we're looking to do in this section. So it focuses on the information related to the impact of the conditions for which the drug product is used for human health and well-being. And to do this, board staff and contractors have reviewed published literature on the impact of the diseases. So again, this summarizes primarily literature review. I don't think we did any de novo research on these specific elements, but we were able to kind of summarize the published literature and then also look and see if there was any Maryland specific information. Next slide. Okay, so the last section that we're going to go over today, and again, this is primarily to kind of show the work product that we'll be providing, is to go through the regulatory approval and market context. So the regulatory approval and market context section provides information on how the approved uses of the drug have evolved over time, and provide information about the strategy behind such changes, including 3 key elements. One is an analysis of the prescription drugs products approval process. The second part is an analysis of the prescription drug products shortage status. And then the last part is an analysis of the market context for the prescription drug product, including the prescription drug products lifecycle management, patent management, and regulatory exclusivities and product copying. In the sections that were published, I think we primarily focused on element 3.1 and 3.2. 3.1 kind of just goes over the different approval processes that are available. So Christine, if you're available to scroll down. For 3.1, it's kind of a narrative about, and this is going to be on page 15, Christine, I think. Yeah. If you keep going to 15, sorry. Yeah, there you go. Yep, that's it. So you can see it's a narrative of the different approvals. And again, for this dossier, we're starting with Farxiga, but this same process will occur for each of the drugs as we go through this process. So it's a narrative of the different approvals that were undergone, and it'll allow you to kind of see the sequence of how the drug, kind of came to market and which indications it was used for. If you scroll to the next element, Christina, so down to 3.2, you can see that we do look up the drug shortage status. And then if you scroll down, this actually might be the last one. So we haven't published 3.3 yet. One thing to note, particularly on 3.3, is that some of this information is going to be based on information submitted in the RFI, the request for information. And a lot of that information has been designated as confidential and proprietary by the folks that submitted that data. So that will be kind of redacted or for any public version that's available. So that's going to be separately submitted to the board kind of through our process for sharing confidential and proprietary information. So this is the general context of how we plan to go through the dossier. I think we want to make sure that the board reviews this document element by element. I think we expect the full dossier to be in the range of probably about 100 pages, probably between 70 to 100 pages for each of the each of the drugs. And again, this is meant to be the comprehensive list, kind of checking each element to make sure that the element is available to the board for their consideration. And then ultimately the board can identify specific issues that they are able to consider that might be the most useful for them. So I think this is the exercise that we wanted to go through in today's meeting, but based on any kind of board feedback or public feedback, we'll just take that into note. And then we expect in an upcoming meeting to kind of go through the full dossier, complete the dossier for Farxiga, which we're doing now, and then also complete the dossier for Jardiance. All that information would be presented to the board, and then ultimately the board would take that information into consideration. And then we'll also go over the process of how the board would go about making their preliminary affordability determination. Any high-level questions here? I know a lot of the more interesting data that the board wants to consider will be considered in a future iteration of this dossier. So probably not much on the substance here, but if you have any guidance or feedback on what would be most useful for the staff to provide, we would welcome that input now.
How many more elements are coming?
We expect there to be 7 or 8 total elements. But sorry, the elements are we expect 8 sections, and the elements map to COMAR regulations. So we can count them up for you. We'll send that number to you. But for each COMAR regulation, it maps to a single element. The reason we did this mapping exercise is because the way that they're organized in the regulations, they're not intuitive. They're like clinical information, like a regulation on clinical information. It can be like in 2 or 3 different spots within the regulations. So for the purposes of the dossier, we pull them all together and reorganize them as quote unquote elements. So you'll see as you go through the dossier, we've called it an element. So there's the sections that are kind of broken up into these general categories. And then each section will have elements within it that are mapped to the regulation. So we do want to make sure that it's very clear for you guys that you have checked the boxes of considering each of the different things that you're allowed to consider in the regulations. But that's why we've had to kind of go through this kind of mapping exercise that you see here. It allows us to organize it in a more intuitive way for the organization of the dossier, while also making sure that we're still ensuring that you receive, you check the box of saying that we have considered everything that we need to consider as part of this review. I can give you the number of the exact elements though, probably after this meeting, if that's okay. We need to count them up for you.
Okay, and then I was just sort of the timeline.
Yeah. Oh, in terms of timeline, so I think there are drafts of the documents that are ready to be published as soon as they go through clearance. So we expect to publish the iterations of the dossiers in the near future, similar to this iteration, but it'll just be the full dossier with all the elements. We just need to kind of clear them for the final version. Right now, you have a meeting scheduled for May 19th, so you can certainly, we can do some of this business in that meeting. Otherwise, you can see when the documents are posted and we can discuss other options at another time.
Thanks.
Okay. Dr. Anderson?
Yeah, sorry, I'm late. You sent me to Google, not to Zoom, and I
Oh,
my life in Google. So that's why I'm late. So I have a couple of questions. You might have covered them while I was away. So the first one is the source of the clinical guidelines that you're using. That's very important, and I just don't see in the dossier the source.
yeah, we should be heavily citing to all of the resources that we're using. So if they are not in the guidelines, or sorry, if they are not in the dossier, they should be in footnotes in the citation. So if they are not in the version that is posted, we will repost the version that has the footnotes. And I apologize if they're not in there.
Let me try my question slightly differently. Is this from peer-reviewed journals? Peer-reviewed journals then changed because they were written in 2020, et cetera. Is there a way to update or keep these clinical guidelines current?
Yes, I understand the question now. So it's the documents will be a point in time reference. So I think the board can always consider revisiting these documents if we find out that there's a major update to clinical guidelines. So right now, I think what we would say is all of the clinical guidelines that reflect the standard of care are as up to date as the publishing date of the dossier. So for example, if we were to, I think, this is a draft of the dossier, so ultimately you'll have to finalize a report. And I guess if there's changes that happen before then, you would have the opportunity to make those updates. But otherwise, they reflect the most recent recommendations from the different groups that we're looking at. So these again are generally accepted standards of practice, such as medical societies representing each of the different specialties that oversee this, different public health associations. So in terms of how we came up with the standard of practice, we basically look at all available guidelines that are generally used in practice and use those as the resources. Not sure if that addressed your question.
Well, yes, but as you know, they're not all going to agree. And so, how do we essentially decide which ones to take? Is it, if it's on any of them, is it on all of them?
I understand.
What's the approach here?
Yep. The way that we have handled this, and I think we will probably handle moving forward, unless given guidance otherwise, is that we want to provide a comprehensive summary of what's available. So our goal is to say, these guidelines say this, these guidelines say that. If there's an important or substantial disagreement between guidelines, we would then probably flag that for you. And we want all that information to be available for you to consider. So then when you do your deliberations of deciding, if a drug causes an affordability challenge, you can kind of discuss and as a board decide if and how you want to handle any kind of conflicts between different sources.
I have some more questions, but Stephen's raised his hand.
Yep.
And he's our clinician, so I want him to jump in.
Yeah.
Dr.
If you get 3 doctors in a room, you're going to get 5 opinions as to the best way to treat a particular disease or anything. So you got to deal with, sort of consensus of best practices. And that's often published in various journals and, compendiums of practice. and that's where we'll find these things. And diabetes and Farxiga and the treatment of diabetes has been going around for a long, long time. So I'm not sure that the specifics of that is going to make a big change as far as our ability to do affordability challenges.
Understood. Yeah, and I agree. I think it's good that we are having these conversations because while it might be a clear-cut case in certain disease states, so I'd imagine this is probably one of the cleaner disease states that we would look at. It is important for us to kind of think through how we would handle more complicated situations. And then just to kind of echo what you had mentioned, I think one of the things as well is that this dossier kind of represents things at the population level. So all we are trying to do through this work is verify that the data that you're reviewing is reflective of standard medical practice. So what we want to avoid is you making an affordability determination based on a physician that is doing something that no other physician would agree that they are doing. What we're doing on our side is making sure that the data that you are seeing, both in terms of utilization and then some of the pricing data, reflects the recommendations of the standard practice, which we've determined to be based on clinical guidelines. And Dr. Akar, I agree that with your assessment of the sources of those folks, compendia, journals, those kinds of things. Okay.
All right.
Dr. Anderson?
My next question is about element 3-3.3. Does
Yep.
this cover all the drugs considered therapeutic alternatives or just the single drug that's under review?
3.3.
It's right in front of it. It's right in front of
Yeah.
it. So it's the market context. So is it
Oh,
just,
okay. I see.
is it about Farxiga or Jardiance, or is it, metformin and all the different activities that are involved? And that would be a huge undertaking, but I just wondered what you were planning on.
Yeah, so market context is a pretty broad term, and the way that we've been reflecting on it is through the kind of the descriptive elements on the back end, so the life cycle, patent management, regulatory exclusivities, and product hopping. So I would say that this section focuses on those specific elements, and then the context of that drug in the full market, I think, is represented throughout the dossier because there is a lot of comparison to the therapeutic alternative. So I would say what you're asking for is represented through the dossier, though not necessarily through this element, it's through some of the other elements.
Okay. And last question, RX norm. There's a whole series of places where you get therapeutic alternatives. You've chosen one. Could you explain to me why you've chosen this one as opposed to alternatives?
So this isn't for therapeutic alternatives. This is just the comprehensive list of the NDCs represented by this NDA.
Oh, okay.
So yeah, but it is a useful database, and I need to get back to the board on this. It may be as simple as this is the database that is used for mapping, like the database that we're using. We use the all payer claims database, then we mapped it to other databases. But basically, the way I understand it is that RX norm is kind of an aggregator of different sources. So our understanding is that it's the best database that's available to get a comprehensive list of NDCs. Again, it's so comprehensive that it includes like NDCs that we don't see in our claims data even. It's an overly comprehensive list, but that's, I think, important just to make sure that our work is fully comprehensive. And also just noting that it's a pretty official version too, because it I think is managed by the Library of Medicine. So this is the National Library of Medicine. So we also just look at it as kind of a gold standard database for this specific purpose.
No, that's fine. The way it was presented to me in the thing, or at least as I read it, let's say it that way, it was more about therapeutic alternatives than just a list of NDCs. A list of NDCs, I think, is fine. I just read it as therapeutic alternatives.
I think we will table the discussion for therapeutic alternatives for when we talk through those other elements. We did mention when we created the therapeutic alternative list, I guess this is almost close to a year ago now, that the way we did come up with the therapeutic alternatives is by referencing the clinical guidelines that we just talked about in the section above. So basically, we looked at drugs that basically treated the same indication at the same standard of care. So if it's a first line or second line or third line, kind of all the drugs that are in that space, and then also reflecting, treats the same comorbidities and things like that. We'll go into depth on exactly what the therapeutic alternatives represent in the next presentation, but we appreciate that feedback. All right, any other questions? Again, we started with the 3 easy sections, so I think the conversation will get much more interesting for our next meeting when we go through the full dossier. But did want to just kind of show you exactly the work product that you're going to be seeing, and any guidance that you wanted to provide kind of on the front end before we publish these full dossiers in the upcoming weeks.
A question, Andy. So how do you see the staff organizing what's to come? Is it in terms of when you start getting into the economic analysis and summarizing that literature, are you organizing that by clinical conditions, by some other metric? How are you kind of conceptualizing that process?
Yeah, so for each of the different elements, so I'm scrolling through, a lot of them are not going to be specific to the indication. So the clinical indications, I think you should kind of take on the front end. Everything else is going to be primarily utilization based. So it's just going to be the overall stats of like, here's the volume of drug, and then, the different metrics that come along with that. So units, patients, those kinds of things. It isn't going to be necessarily condition specific. So that's an important thing to consider as you look at this work. But I think the board should feel, be able to have conversations about the implications of that over time. So I think, one of the big things that we have explored, but I don't think there's data available, is just trying to associate different volumes of utilization to different indications. That work is not possible based on the data that we have, but I think we can certainly kind of explore it as much as the board would like us to, as long as it complies with the element within your regulations. I'm not sure if that answered your question, but basically we're going to go through kind of each of the sections. So there is going to be a section that's just called, go ahead.
Mm-hmm. Yeah, no, I think that's certainly what we'll have to consider. I think there's some nuances once we get into the studies with regards to the disease conditions they're studying, the drugs that are being studied, how are they being grouped, and are they allowing us to get to DAPA specifically? I'm not super confident that we'll always have data that's relevant for Maryland, but at least for the clinical conditions that we're interested in, heart failure, diabetes, end-stage renal, and so on, will those be parsed out? And will the data be specific to this drug versus something that's
I think
at a
I
class
understand.
level?
So I think the extent of the clinical information will be reflected in the 2 sections that we just went through. So as much as we can answer that in those 2 sections, and I now hear, I understand that this is something that the board would be interested in, so we can certainly try to dig into that as much as we can. And then also in terms of comparative effectiveness. So again, when we are looking at the cost effectiveness research and the comparative effectiveness research, it is often a comparison between 2 different therapies that are, used for the same indications. And as much as basically for those sections, we summarize and reflect the information that's available in the literature. So I think we would be able to articulate and let you know that, like, when you compare this drug to other drugs within the same class, here are the outcomes. When you compare it to standard of care, and it's usually articulated within the study, then, here's the outcome. And, for the cost effectiveness research, go ahead.
Okay, I think that's good. And then I see a couple more hands up. So just one point I might make is, as we're being presented with the data and the updates to the dossier, so for utilization studies, they do have to specify the condition, right? What disease cohort they're studying. And so a lot of comparative effectiveness studies may focus on diabetes, but for what we've seen, we're interested in diabetes plus, right? And so just being able to just specify that, okay, the limitation here as far as this comparative studies that is looking at diabetes, because we know that the indication is much broader. And a lot of studies that I've seen, at least on the costing side, are quite focused and not as broad.
Okay, very helpful. Yep, we will look at that. Dr. Ruckauer?
Yeah, the only point I want to make is, we get into the minutia of all of these things, and the longer we take to come up with our regulations, some other new drug is going to come up, in the pipeline and blow all of our analysis out of the water. So I think we need to move along, to be able to get things done.
Great, thank you. Dr. Anderson?
I mean, let me second what Stephen just said, is that, we've taken now almost 40 minutes to go through the 3 easy ones. It'll take us longer to do the 5 harder ones. And I doubt that we would be able to do it in one session. So I do think that we do need to try to figure out if we can put something on before the May meeting so that we can talk about the difficult issues. But that's just my request.
Okay, yeah, we'll certainly take that back. And I think most importantly, just getting the information before you and the public as soon as possible. I think that can also kind of help with this conversation as well. So. All right, any other questions on the dossier? We look forward to getting this back to you, and we do expect it to be the topic of an upcoming board meeting. We appreciate the feedback, and we do look forward to moving this process forward. Any other comments or questions? All right,
Great,
Christina,
thank
if you
you,
want
Andy.
to.
Yep, thank you very much. We're going to move on to item B under 4 in the cost review study, and the chair is going to remove the first item that was going to be covered in closed session. So the GP 3-305B13 HG 21 2C03E will not be taken up. We will only be, and I'll entertain a motion under the general provision for closed session on 3-305B7 to receive legal advice and counsel and maintain confidentiality, attorney-client privilege in a closed session. Is there a motion for that?
So moved.
A second?
Second.
Second. All those in favor? Aye.
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 We're going to go into closed session. I apologize to everyone else. I generally don't like doing this, and I've told the staff this, but we unfortunately are going into closed session in the middle of a meeting, and we will be coming back. Normally, I prefer to have the closed session at the end of the meeting so everybody can just go do their own thing and not sit around and waste time. The only thing that I know, just so everybody knows, we will be taking up item 5. And that's really the only thing of any, and that's just the approval if we decide to approve those as far as the COMAR. Correct, Andy?
That's correct. The cost review study or the policy review process regulations. Yep.
Okay, so Christina, if you could put us into our closed session.
Yes. You're going to get a request for a breakout room, so please accept it.
Okay, Christina, are you there?
Yep.
Andy, you there?
Yeah, we're here.
Yeah,
Can we update the screen to item 5? Or no, we are on item 4. Never mind. I got you.
Yep. Great. All
Okay,
right.
so we're done with item 4. We're going to go to 5.
Great. Thank you, Mr. Chair. We just have a
Andy,
very brief presentation for you, if that's okay.
Yep.
All right, great. So this presentation is a follow-up to our working session that we had in our February meeting. Just to reiterate, the purpose of this presentation is to go through each of the different comments that we want the board to consider, and also provide staff recommendations on actions for any of the comments that may need to be addressed. Just as a summary, we received about 135 pages of comments, and they were shared and reviewed with the board. So we're just going to go through the last comments that we didn't go through in that last meeting. Next slide. We do try to break them up into different sections. So this section is going to be definitions, like procedures on certain topics, and economic impacts. Next slide. So we continue to get a lot of questions and comments about the therapeutic alternatives definition. One specific commenter stated that the definition of therapeutic alternatives is too broad and does not consider for differences between drugs and different populations. Staff recommends no action recommended. This definition is designed to allow for the consideration of all factors in comparing prescription drugs, including the differences cited by a commenter. And we've talked about this before, but at a high level, the way that we've structured our regulations, a drug needs to be considered as a therapeutic alternative if you are going to consider anything about that drug. So, for example, if you're going to be looking at comparative effectiveness literature or anything, if you want to consider anything about a drug that is not the drug under study, it needs to be listed as a therapeutic alternative. So that is why the list looks so broad, but it has kind of different iterations and uses throughout the process. Also, board members, feel free to ask any questions as we go through, and we'll try to go ahead.
So I think, I think we want the largest set of drugs available, and then we can take a look or we can ask you or somebody questions about, yes, but this is only used in this one case, every 10 years or something like that. So I think you've got to go with the broadest, because then you'd be leaving out people and conditions, et cetera. So I totally agree with this.
Great. Thank you, Dr. Anderson. And it does allow us, as part of the research and the analysis, we can hone in on drugs that are more direct comparisons. That's part of the analysis. So this is the universe of drugs that can be kind of looked at and considered. But then throughout the process, we can hone in on drugs that are, more important for certain comparisons. All right. Any other comments or questions? Next slide. This one is a pretty technical question. So one commenter requested the board limit the definition of system net ingredient cost to the utilization of prescription drug products by an eligible governmental entity after accounting for all discounts, price concessions, and applicable to such utilization. We recommend no action, and we don't think the edit actually achieves what they're looking for. We think that this is actually already addressed in the definition. I think what they're actually trying to do is basically say that we're only when we're saying UPL, the universe is just the eligible governmental entities. The only time we use this term is actually to define the UPL, and it's defined for a single governmental entity in the definition. So we think it's accounted for in our regulations, and we do think that this change would be redundant. So I think we recommend no change at this time. Kind of a technical issue. Hopefully that made sense. Next slide. We had 2 comments on the economic impact statement. So one was on individuals with disabilities. So one commenter objected to the statement that the proposed action has no impact on individuals with disabilities, and that disruptions in the marketplace could have devastating consequences for these patients. We've discussed this before, but the proposed implementation of kind of having this happen on the back end rather than throughout the supply chain actually, we think, addresses most of the concerns that were brought up with our economic impact statement, and also explains why we proposed our economic impact statement as we did. So, as the board has discussed in open meetings, the intention is to increase access. So I don't think we would expect, as we plan to implement, any changes in access to the drug for individuals with disabilities or any patient for that matter. Next page, we'll go to the next comment. We can address questions on both of them because they are similar. One commenter objected to the statement that the proposed action has minimal or no economic impact on small businesses, citing a letter submitted in November 24 by a coalition of associations contending that the UPL methodology may result in inadequate or below cost reimbursement to community pharmacies and does not account for the acquisition costs or independent medical practices will impose a large financial burden. And then they noted that this will likely lead to consolidation or closures within the pharmacy community. I think we've addressed this again multiple times, but we don't expect the payment amount from the payer to the pharmacies to change in our current implementation. We expect it to be kind of done on the backside. So we don't see this being a risk. I think it's just a matter of explaining how we plan to implement this. Any questions or comments on these last two comments? All right, next slide. So this is going to be on the UPL procedures and UPL policy options. If you go to the next slide, we received a comment basically talking about the lack of detail regarding the enforcement of an upper payment limit. The commenter requests additional clarity on how the board will hold the eligible governmental entities accountable for the UPL. We recommend no action at this time. So we will have a monitoring program that will look at the impact and ensure that the policies are actually being implemented. And I think the other thing to note is that these are limited to this work is limited to governmental entities at this time. And we expect them to be partners in this process. So we will have kind of a direct line to each of the eligible entities that are implementing an upper payment limit. So just kind of by definition of the process that we're working through, we do expect to be able to note, if and how they are implementing the upper payment limit. Any questions on this? Okay, next slide. The ordering of policy options. So we did receive, I think we referenced one commenter here, but I think this is a general theme that we've seen in comments both in this specific for these regulations, but then also throughout the process. Commenter requested the board consider UPLs only after determining that a non-UPL policy option could not address the affordability challenge, and only after evaluating and mitigating potential obstacles for patients to access their medicine. We recommend no action at this time. We ultimately think that this is an implementation issue. I'm not sure that the board will necessarily kind of rank in priority the different topics, but as we've discussed before, the board will be looking at everything that's available to the state in terms of policy options to make a prescription drug more affordable. So, I think we can certainly say that non-UPL policies will be considered by the board. Any comments or questions here? All right, next slide. There was a comment on the lack of detail regarding how information is used and weighed. I think this is a comment that we've discussed in the open meeting when we're actually creating this process and developing these regulations. But a commenter stated that the regulations lack specific, concrete, and meaningful procedures and standards that explain how a board intends to use and weigh the information. Again, we have no recommended action. The regulations identify the different elements and factors that the board will consider. And it's ultimately up to the board itself to kind of decide how you will consider those factors. Again, there's a number of different situations and circumstances that could make a prescription drug unaffordable. So it's important for the board to have that flexibility. Next slide.
Yeah, but that's a pretty generic comment that you see in regulations across the board. I mean, that could be anywhere.
Understood. Okay. Any comments or questions? All right, next slide. There was a commenter that noted that we failed to adopt a specific methodology. So the commenter states the regulations fail to establish a specific methodology for setting an upper payment limit. So as we've discussed in previous open meetings, there is no single methodology that best fits every situation or driver that may cause affordability challenges, cause an affordability challenge. And then also there's a number of protections and steps built into this process to allow for significant public input. So just as a reminder, this process requires us to publish the selection of the methodology or framework. That's going to be available for public comment, and the board ultimately makes that decision. And then the subsequent actual calculations based on that methodology or framework will also be published for public comment. So that's one way that we do hope to address this issue, but it is important for the board to be able to consider multiple methodologies based on the different circumstances of different drugs. Next slide. This is a kind of a broader than just a reference pricing issue, but one commenter advised caution when considering the implementing reference prices with therapeutic classes of drugs and expressed concerns that payers could be incentivized to implement utilization management or adverse tiering, which could result in non-medical switching of their medications, increase costs, or decrease access for their preferred drugs. I think this is, we appreciate the information. I think this is certainly something the board will want to consider in terms of implementation. Just the potential, impacts of implementation. I think you'll hear kind of some opinions saying one thing and some saying the other in terms of how this would play out. So I think it is important for the board to take all these this information into consideration. So just to thank you for the information to this commenter.
So,
Any comments or questions on this? Go ahead.
Andy, I mean, reference pricing is a very technical term using
Right.
exactly the price of somebody else's activity. And we may choose to do that, but alternatively, we might just look at what other entities are the prices and the UPLs for other entities.
I think that's fair. I think the comment can also probably be read to reference the UPL as a whole versus the specific methodology that we use. I agree that reference pricing is kind of a very specific technical term. We were more commenting on the potential impact of changing the price of the drug and payers' reactions and things like that.
I totally understand that, but if it's really is reference prices, that's a very different thing.
Agree. All right, next slide. The UPL may cause unintended consequences for such as pharmacies refusing to carry drugs. So one commenter stated broadly that the UPL may have unintended consequences, such as pharmacies who purchase the drugs at wholesale acquisition refuse to sell the drug at a loss. I think we addressed this comment a little bit earlier as well, just in terms of the way we propose to implement this for state and local government shouldn't impact reimbursement prices to the pharmacies, so we don't see this as a risk based on how we plan to implement. Any comments or questions? All right, the last section that we have are legal concerns that were brought up. So first, there was a complaint concerning already adopted procedures and assorted legal claims. It references prior comments submitted concerning the aspects of the cost review study process, and the comment broadly states that the statute and the board's implementation and administration of the law is unconstitutional and inconsistent with Maryland's APA, implicating the Dormant Commerce Clause, the Supremacy Clause, the Takings Clause, and the Due Process Clause. I think we appreciate these comments. We have received and considered them. No action is recommended. These pending regulations concern only the UPL procedures, so are noting that we want to stick to that. And then also we disagree with this broad assertion. Any comments or questions on this?
I mean, the legislature's talked about this back in 2019 as well. So this is not new information.
Okay. Appreciate it. Yep. All right, we'll move to the next slide. We did receive comments discussing whether or not the action is quasi-judicial. So the commenter states that in authorizing the board to evaluate the necessity of UPLs, the General Assembly plainly envisioned that the board would act in a quasi-judicial, not a quasi-legislative capacity. We recommend no action on this, and I'll go straight to the next slide on this because I think it's worth comparing these two together. Next slide. We also received a comment asking that the policy review and UPL development be subject to agency rulemaking. So a commenter stated that the predicate processes that lead to the setting of the UPL amount, i.e. the policy review and UPL development, are subject to rulemaking processes as a policy of general application. I don't think we have a specific comment on this. I think the process was outlined in the UPL action plan, and these regulations put that into place. But I would note that commenters are kind of providing contrasting opinions on this. So I think staff recommends no action on this. Next slide. Oh, any questions on this? Sorry about that. Any questions or comments from the board? All right, next slide. One comment proposed that the rules are inconsistent with contested case hearing procedures under the APA. So incorporating comments from a prior letter, the commenter alleged that the draft regulations do not contain procedural protections afforded to participants in a contested case hearing under the APA. Staff recommends no action. The UPL procedure is structured through APA rulemaking procedures with multiple opportunities for public input and comment, not APA contested case hearing procedures. Any comments or questions on this one? All right, and we'll do our last comment slide. Next slide. Various commenters supported the regulations proposed by this Prescription Drug Affordability Board. So we did just want to note and appreciate the comments and that came in and the time that folks put into putting those comments together. Commenters state their support of the Prescription Drug Affordability Board in the process to consider policies to make prescription drugs more affordable. We recommend no action, but we do appreciate. Just wanted to note and acknowledge those comments. Any comments or questions? Okay, so out of this process, we did have, oh, go ahead, Christina, thanks. A series of recommended revisions. The first one, and we alluded to, oh, I guess we'll go over this. For the first one, we recommend replacing methodology with framework throughout. One of the comments that we presented on in the working session at our last meeting was just kind of confusion with the term methodology itself. Basically what we're doing is more of a framework. That first step is like, how are we going to think about this problem and proposing and calculating the actual calculating UPL. And the comment basically said that methodology almost implies kind of the next step that we'll be doing, which is the actual calculating. So to be responsive to that comment, we recommend replacing the term methodology with framework throughout. The second point is we wanted to clarify the broad scope of the designee by removing the term staff in the hearing provisions. So we just wanted to be responsive to one of the comments that came in on that provision. And then finally, this is something that we flagged in our last meeting that we were going to recommend. But there was a comment basically talking about the comparison of the process for the non-UPL policies versus the UPL policies. So we recommend providing some clarity by amending COMAR 1401-0505B2D non-UPL to the possible implementation of the policy through legislation, regulation, or enforcement. And for the purposes of clarity and completeness, adding in 1401-0505C2 for the UPL process, the consideration of the UPL policy option, the strengths and weaknesses of the policy, potential impacts for the policy, and possible implementation of the policy through regulations. All of these changes have been made in the regulations that are before you and posted on the website. Changes, the double brackets means that it's a removal from the original version. And then the underline are terms that have been added to the regulation. So all these changes are reflected in the PDF that's available, or the version that's available to you today. And as you go through it, those are the two different notations that might be relevant. So that's the presentation from the staff. Any questions or comments from the board? Great. Well, Mr. Chair, I will turn it back to you.
Thank you very much, Andy. I'll entertain a motion for approval of the regs.
So moved.
Jerry, is there a second?
Second.
Stephen, thank you. Let's open it up for discussion. Any discussion or questions or comments as submitted?
No, I think we've looked at this multiple times, so I think I'm comfortable with it.
Okay. Hearing none, all those in favor, aye.
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 Opposed? Ayes have it. Approved as submitted with the changes. Thank you very much. Thank you, Andy and Michelle and everybody. I know it's been a long process. Andy, we're approaching the hour and a half. Do you have a quick update for staff and public about meetings and your staff updates?
Yep, we have 3 quick updates. One, just with the regulations, the staff will submit them as soon as possible. There are some deadlines coming up, so we will keep you updated on when the regs are in the register, and then the implications for when they'll be final based on that. We did want to note that we're going to propose 2 board meeting date changes that have been posted on the website. For the September meeting, we plan to move it to September 15th, 2025, Monday, September 15th. And then for the November meeting, we're going to move it to November 17th. Both of those are to address different holidays. Also, just wanted to note, and I think the board chair may cover this as well, the May 19th meeting, we had talked about that being in person, but there is an event happening in Annapolis that may make it difficult to do an in-person meeting. So we will plan to have that as a remote meeting, or a virtual meeting, excuse me. Other general update is we will be posting 2 positions for the Prescription Drug Affordability Board staff in the very near future. So if anyone listening has any good candidates, we have a policy analyst position, a quantitative policy analyst position that should be available, and then also kind of an administrative program manager position as well. So very excited to hopefully add some new members of the team, and we will share that. We also have a legislative update if Christina is available to provide that.
Thanks, Andy. The PDAB continues to track legislation, answer questions for legislators, and provide information as necessary. We would like to provide a quick update on Senate Bill 357, House Bill 424, which is the Prescription Drug Affordability Board Authority for Upper Payment Limits, Lowering Prescription Drug Costs for All Marylanders Now Act. As mentioned previously, this creates a process for the board to set upper payment limits for payers in Maryland after the board successfully implements upper payment limits for state and local government. This bill passed through the Senate and has a crossover hearing this Thursday in Health and Government Operations. So we just wanted to let you know about that. And then we also wanted to flag Senate Bill 306, Workers' Compensation, Prescription Drug and Pharmaceutical Services, Reimbursements. This crossed over to the House and has a hearing on Wednesday this week. This bill will require the PDAB to examine multiple topics related to prescription drug affordability within the workers' compensation program.
Mr. Chair, that's our administrative update from staff.
Well, for the board, maybe Christina, could you just spend a second on both bills as to the posture that they're in? I know both bills, unfortunately, have been amended that are not helpful for the board, and I think it would be wise for the board members to at least be aware of what the possibilities are.
Yeah, so I will say that the most recent amendments have added 3 possible members to the stakeholder council. I'm going to let Andy elaborate on the more technical changes for the Prescription Drug Affordability Board. And we are looking for some minor amendments possibly to the workers' compensation bill.
Yep.
Andy, do you want to speak
yeah.
to
So for the expansion bill, I think the chair might be mentioning that as part, so basically the bill works as the board would implement upper payment limits for state and local government for at least 2 drugs, and then after a year, you would then be able to start setting upper payment limits for the full state. So that's the kind of general structure. What one of the amendments does is, as we transition to that, it adds additional reporting requirements for our annual report that we publish, examining potential impacts to a number of different factors. So it has probably half dozen reporting requirements, just analyzing the impacts of an upper payment limit. So we did want to note that it will be additional kind of staff time and resources that we'll have to put into for our annual report based on that.
So Andy, I mean, that's fine. I mean, I think we need to do that, but I think the legislature's got to recognize that within a year, will have very limited information about the impact. I mean, the data systems just don't work that quickly to determine, whether or not we've saved any money, whether or not anybody's had access problems. The data systems, I mean, I work with data systems all the time. It's a 2-year, 2.5-year lag in many cases. So, I think the legislature should recognize that it's fine to ask, but they're going to get limited information. Whereas in 2.5 years, they would actually get substantive information. So that's their choice. But just recognize as a researcher, we just need to tell them they're not going to get much.
Okay. Yeah, I appreciate that. And I think, there is the wording is based on available data. So I think they appreciate that there may be kind of limitations to the data that it's available. I think a lot of our work will hopefully, try to answer some of these questions. We've talked about developing a monitoring plan, so we can also try to be responsive through some of that work as well.
Yeah, Jerry, and I don't really care about that because no one reads any of those reports, having been on all three sides of this issue. But this little entity cannot allow the start of every time a bill comes into the legislature, somebody puts another report on it. You will be doing 30, 40, 50 reports inside of 5 years. So to me, the bigger issue is keep these bills clean, amended out, and just keep our reporting as limited as possible to things that are absolutely essential for what we do, not to make someone else happy.
Totally agree with you, Van, on that. I'm just also telling them that they're not going to get valuable information, even if they did read it.
But they don't care. I mean, that's never, it's people just trying to amend the bill for whatever their specific reason is. I mean, they generally don't care what the report says.
But yeah, staff can be responsive, but I think Dr. Anderson brought up a good point, just that they're difficult questions to answer with limited data. And then Christina mentioned the workers' comp bill. I think we would just note that, it's definitely an interesting issue. It asks us to kind of examine how the workers' comp market looks different than the commercial drug market. I think the only thing I would note is just based on what the chair had said, we have limited resources, so we're trying to partner with other organizations. For example, the Department of Health and the Healthcare Commission have a lot of experience with these kinds of reports and have data. So we're just looking for partners within the government to continue to do that work. So yeah.
Great, thank you. Thanks, Christina.
Right.
Hang in there. There's only a couple more weeks left. Let me go around the horn and see if anybody has anything else. Andy, are you clear staff-wise?
Nothing else from
Stephen?
No, I'm good.
Joe?
I'm good.
Jerry?
So I would hope that we consider a meeting between now and May, just because we've got a lot to talk about, and I don't think we could get all the discussion done in May. So I think we want to have an interim meeting and then have a more definitive meeting in May. But that's something that other people might not want to do.
All right. Barry?
For me, just wanting to stay in touch with the staff on any recommendations from the PDESC with regards to patient engagement on patient burden as we round out for Farxiga, the cost review and the remaining elements. That would be something that I'd be particularly interested in getting. We've seen data for Maryland, we've seen data for the US, but even for Maryland, I imagine this differential burden of the conditions we're looking at by jurisdictions. I wonder if some of that could guide targeted outreach given the limited staff. We do have limitations in terms of staffing, but hopefully no shortage of ideas in terms of how to get some contextualized data for Maryland. on the patient burden. So any input from the PDESC would be really helpful. That's it for me.
Okay. Christina, the next stakeholder council meeting in April is the 21st?
The 28th, at
28th.
2:00 p.m. And I also just put that in the chat because I forgot to mention it
Okay.
earlier. Thank you.
Okay. Anything else for the good of the cause?
Move for adjournment.
Move second.
Second.
We stand adjourned until our next meeting at this point in time, which will be Andy, May
19th.
May 19th. Thank you all very much. Enjoy the rest of your day.
Thank you.